At the 882-bed Dallas-based Parkland Health and Hospital System, marrying physical and behavioral health is not just a saying, it's a priority. In this three-part podcast series, we talk to several leaders at Parkland Health and Hospital System about how they're integrating physical and behavioral health through suicide screening and creating practical approaches for sustainability across all departments. Welcome to Advancing Health, the podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. This episode features Rebecca Chicky, Director of Field Engagement and Behavioral Health Services at the American Hospital Association, and David Herman, Motivational Interviewing Trainer of Suicide Risk Assessment and Intervention at Parkland Health and Hospital System.
Welcome to another podcast in the American Hospital Association's ongoing series of podcasts where we focus on important issues facing clinician leaders and behavioral health providers. I'm Rebecca Chicky, Senior Director of Field Engagement and Behavioral Health Services at the American Hospital Association. I'm joined today by David Herman, Motivational Interviewing Trainer of Suicide Risk Assessment and Intervention at Parkland Health and Hospital System in Dallas, Texas. Today we're talking about motivational interviewing and how it has been used and is used at Parkland Health and Hospital System to assess patients for suicide risk. To get us started, David, please tell me a little bit about yourself and your role at Parkland Memorial.
Parkland Health Hospital System is a large safety net healthcare system serving Dallas County, Texas. And in the beginning, Dr. Jessica George, who is the trauma psychologist for the Reese Jones Trauma Center at Parkland, worked with me and the team on the development and implementation for the hospital-wide suicide screening procedures. She also worked with me on the initial development for using motivational interviewing as the assessment and intervention for patients identified through the system-wide hospital screening program. I myself work as a psychiatric social worker in Parkland's emergency department. I have a board-approved supervising licensed clinical social work status and have been a motivational interviewing trainer for around 19 years. Most of my workday involves seeing patients in our large medical ER who are identified at moderate or high risk of ending life by suicide and those with emotional and/or behavioral health concerns. And additionally, I've served as a consultant and in-house training designer for agencies, clinics, county health departments, and research projects using motivational interviewing, creating trainings that take research to practice, such as using motivational interviewing with initial trauma assessments, with the Commitment to Change Forensic Cognitive Behavioral Therapy program, and a number of basic MI trainings.
Thank you, David. But help us break this down a little bit. What is motivational interviewing, and how does it work?
Motivational interviewing is essentially a way of being with a patient that enhances the patient's sense of autonomy and self-efficacy within a collaborative relationship with the clinician. The spirit and principles and skills of MI address and assist the patient with resolving ambivalence toward adopting health behavior change. MI was originally developed by William R. Miller and Stephen Rolnick in the 1980s with a focus on substance use disorders, and has since been adapted and empirically supported for many other health behavior populations. So the process of motivational interviewing involves engaging and focusing the patient on a specific topic involving ambivalence about a health behavior change, and then creating an active environment for the patient to explore their thoughts and feelings about their ambivalence, and then the patient developing a plan of their own making for what they will do in relationship to the change. All of this takes place in the context of a non-judgmental, self-efficacy supporting collaborative relationship. And we felt that motivational interviewing would be an efficient, effective brief intervention, especially suited for health and hospital systems, agencies, clinics, and specifically our ER and our outpatient clinics.
How did you move then from the idea to implementation of using motivational interviewing to enhance suicide risk assessment?
Well, psychologist Dr. Kimberly Roten, associate professor in the Department of Psychology at the University of Texas Southwestern Medical Center, led in the initiation of systematic universal screening for suicide risk in the Parkland system. Dr. Roten developed the Parkland algorithm for suicide screening, which is a clinical response algorithm that guides patient care based on responses to the screening questions. So in tandem with Dr. Roten leading the development of an effective suicide screening process, Dr. George and I took the lead in applying motivational interviewing for suicide assessment and intervention as an option for responding to patients identified through the Parkland algorithm for suicide screening. And using motivational interviewing with patients identified at some risk of death by suicide, it was nothing new. Dr. George was familiar with MI. I had done other MI trainings and was familiar with MI applied to patients at risk of death by suicide. So our task was how to implement motivational interviewing applied to this identified population in a system as large and diverse as Parkland. After providing a literature review and supportive research, management and the clinical team responsible for the implementation of the suicide screening program gave approval for us to proceed. So initially, Dr. George and I collaborated together to build a motivational interviewing training to fit in the Parkland flow of work. Our goal was to produce a training product that was transferable and applicable between departments that met all the time constraints in our busy service areas. So we worked diligently on it for several months, and our initial attempt at producing the training failed to fit the flow of work parameters and in other ways. So we put it aside for a couple of weeks, came back together, reconvened, and brought in colleagues from different service areas within Parkland and experimented with training formats to produce what we have now. So our current MI application with this identified population is very customized for Parkland. We have 3 short online trainings with small group practicums. And we've customized an online basic MI training, and we follow it with what we call a real play instead of role play practicum. And this kind of practicum allows people to demonstrate proficiency with MI, and it also provides the clinicians a personal experience with being involved in a motivational interviewing session. And we follow that up with customized online training using motivational interviewing with suicide risk identified patients. And we added another element of it using MI with substance use disorders. We followed those with the practicum to demonstrate proficiency. One of the highlights of our application here is the immediate application of the learned MI skills to practice, thus enhancing patient care and clinical expertise. Now, the Park social work clinicians receive CEU credits for completing our training. And 2 key points fitting motivational interviewing training into the context of the Parkland system and with the patients that were identified at some risk of death by suicide. The first was resistance. Patients usually are reluctant to discuss suicidal ideation due to the attached stigma. There's just some inherent concern about talking about something so daunting. And clinicians also express concerns about bearing responsibility for and not feeling competent with independent evaluation of suicide risk and the responsibility for saying someone is safe to go home. So with motivational interviewing, we took the principle of rolling with resistance to address both patient and clinician concerns. We turned to research that supported reframing suicidal ideation as ambivalence, and that seemed to lessen the resistance in this particular area. So we continued to roll with the resistance by incorporating the ambivalence theme in trainings on MI conversational structure and skills and the different topics that we touched on throughout the training. So how motivational interviewing works in this particular population. Motivational interviewing elicits the individual's intrinsic motivation for change, and that is identified by their change talk. Now, in the context of ambivalence toward living, that change talk is about continuing to see life as worth living. So that's what we wanted to train the clinicians to listen for in their MI sessions. So in light of fitting motivational interviewing with suicidal ideation, training within Parkland's workflow, the Change Talk themes involve incorporating research from self-determination theory and motivational interviewing by identifying themes within what self-determination theory identifies as autonomy and competence in relationships. In doing so, we were able to take protective factors, operationalize them as when I have a sense of being a person and affecting my own mind and body, my relationships with others and life in a way that is meaningful to me, I feel like life is worth living. On the other side, risk factors were operationalized as when loss or damage occurs to what is important to me in affecting my own mind and body, my relationships with others, and my relationship with life, I experience some level of ambivalence about continuing to live. So since motivational interviewing focuses on resolution of ambivalence through a collaborative relationship, supporting autonomy and self-efficacy, the MI session seems to be a good fit. And it actually becomes a protective factor in and of itself as you're engaging the patient in using critical thinking skills to evaluate their own ambivalence within the collaborative relationship with the clinician. It's a lot to verbalize and talk about, but that's essentially the basics of what we are doing.
I have so many thoughts. One, I wanted to compliment you first on your honesty, the honesty that I hope the members heard that your first shot at implementing this didn't work, but you didn't give up. And you went back to the drawing board and created what is an impactful and successful program. Another question popped in my mind as I was listening to you that I'm sure some of the listeners might want to know, and that is, how long does it take in terms of the training itself? You described a number of steps, but is that a day, 4 hours? Could you give us a general sense of that, and is there retraining annually?
Well, Parkland is an enormous system, and yet within that system, they give you so many opportunities to develop programs. I think the best thing I can say is that Parkland Health Hospital System, my manager, my supervisor, the directors, they all have been so patient and so supportive of giving us the opportunity to produce this. It has been 5 years in the making, and we have experimented and failed in a lot of ways, but we finally got it down to what fits in the very fast-paced work at our hospital system, especially in the ER. We have a half-hour basic motivational interviewing training. People go through that online, and then we immediately follow that up with a half-day practicum. We're working with people who have some familiarity with motivational interviewing, and those who don't, the way we've designed the online training and the practicum pretty much fit into what we usually do with motivational interviewing, which is a 2-day training. We've managed to streamline that down, and the practicum is where we get a lot of trainings. The practicum is about 4 to 6 hours. The online training is 30 to 45 minutes. We follow that up with the same motivational interviewing applied to suicidal ideation identified patients and with substance use disorders. And that's, again, about a 30 to 45 minute online training followed with, anywhere from 4 to 6 hour practicum. I think the key is the efficiency that we are able to achieve with the online training and with the practicum that really makes a difference. And plus, the clinicians are, getting quite a few CEUs, so there's a bit of motivation there. And, we're doing something like this in our big hospital system, quite frankly, is pretty exciting for the clinicians. They don't have a lot of opportunities to get this kind of training, and we're doing it in-house. We're not sending them out somewhere and telling them to come back. We're doing it in-house, and these are people that we work alongside every day. So everybody that's involved in the training is a coworker.
David, you've definitely articulated many of the ways in which motivational interviewing is different from, say, standard screening. And you mentioned the impact, or at least one of the impacts that you see in that the motivational interviewing and the plan that the individual helps create becomes almost a protective factor for them. Could you share more of the impact that you've been seeing from this use?
The biggest impact I have experienced, and my coworkers who are practicing this have experienced, is in the patient response. There is so much difference in coming into a room and starting to ask about the typical question and answer format that's used to determine whether or not somebody is high risk or low risk for, ending their life by suicide. So instead, we come in the room and we actually very comfortably start up a conversation. We tell them who we are, and we follow our system's identification of the patient. And I think the key thing is when we start the conversation, we say, at some time you've had an experience where you've wondered if life was really worth living anymore. And yet here you are, you're still with us. What are you doing to keep yourself going? And we modify that depending on if it was in the past or if it's something current. That seems to put the patients at so much ease that they just start talking about their experience. So I think the reframing of suicidal ideation as ambivalence about living, and then affirming them by saying, you're still here with us. You must be doing something that's keeping you alive. You're really managing the distress of that ambivalence quite well. So, tell me about that. I think it almost inspires the patient by letting them know there's somebody here who actually is interested in this terrible experience I'm having about wondering whether or not my life is worth living. And they want me to talk about it. I think they genuinely get the sense that I'm about to be understood. And when you do that with motivational interviewing, the conversation itself is a protective factor because the patient is no longer alone with their thoughts of whether or not their life is worth living. They have let you in, so they are not alone anymore in the experience. And they finally have somebody who's going to allow them to talk about the reasons they don't want to live anymore without judging them or trying to make them think differently. And I think that's the most exciting part of this that I have seen. And when my coworkers come up to me and talk to me about, I just went and saw this person and they were high risk and I used this approach and it was so exciting to get to be the one that sits down with them and hears them and lets them think about things and come to whatever conclusion they come to about whether or not they want to keep living. So I guess that would be my answer.
No, that's exceptional. You help them see the value and feel valued as an individual. That's what I heard.
Yes.
We all want to be valued. What is our value here on earth? And it sounds like motivational interviewing helps reconnect an individual and revalidate their value.
We have to realize we are walking in on complete strangers, and we've never seen these people. The people have never seen us. And just the fact that our clinicians can engage them in a conversation about something so daunting as thinking that you want to end your life, yes, it definitely, the conversation itself is an affirmation of their importance as an individual. And we let them come up with their own reasons for continuing to live. And that can be difficult for clinicians who have different sense of values about why a person would want to live and all that. But it is very rewarding, and I think it seems to be very rewarding for the patients.
So as we wrap up the podcast, what advice, maybe one or two steps, would you suggest for someone who might be interested in starting the use of motivational interviewing related to the assessment of patients for suicide risk at their organization?
First would be to assess the workflow pace in the organization and design the training to fit within that pace. That does a couple of things. It frees up the trainees They don't have to go outside the agency to get training. It's right in their space, if you will. And it shortens the time between training and actual application. And the second thing that we've learned at Parkland is to use organizational resources to complete and implement the training. Whatever those resources are, that's what you use. A lot of times people send people out for training, and then they have to come back in and remember what they learned. But if you do it in-house, the best that you can, then it shortens the time between training and, actual application. It's a daunting thing. We didn't try to reinvent the wheel with applying motivational interviewing with this identified population. We just tried to be creative with the wheel that was already there and found that it was very rewarding clinically and for the patient care. I mean, if people are interested in how to do it, and they have very limited resources, they're more than welcome to contact us. We'd gladly supply any assistance that we possibly can to help other agencies or smaller ERs or big hospital systems with assistance in, developing their own in-house training.
Well, David, this has been incredibly inspirational, informative, and valuable. I know that our physician leaders, our behavioral health leaders who are listening to this podcast on using motivational interviewing as a tool to address suicide risk will be considering ways in which they can begin to take the steps on their own journey to be as successful as you have been at Parkland. So thank you so much for your time, your willingness to share your expertise.
Thank you very much for having me on.
And that ends today's podcast.